Thank you very much for the kind introduction. Can I share my screen? Okay, thank you. I share first my screen. Okay, so and I put it in presenter mode. I think you can see my screen now.
Yes, we can.
Yes. Okay. Thank you very much. So, I'm very thankful to present here today and give this lecture here today for you. And I was asked to give my insights in how we treat IBD currently with the shifting paradigms. We have shifting in how we monitor patients. We have also shifts in the treatment of patients with IBD. So, first of all, the learning objectives of today. Um, I try to move. Okay, learning objective of today. We look how to optimize the monitoring strategy and how we do it here in Belgium. We look deeper into what treat to target is and how it evolves over the last years, treat to target. And also we look how we can achieve targets with the new molecules, the new IL-23 and the new JAK medications. I will first start with a case. It's a patient that we saw, and I think this is a very nice case because this case really reflects what treat to target is and how we can optimally use our medications that we have nowadays in patients with IBD. And this is a patient here with ulcerative colitis. It's a female patient of 38 years of age, and she has now a disease duration approximately of 3 to 4 years. So initially, she was diagnosed in November 2020, and she was treated with for her rather mild ulcerative colitis, left-sided ulcerative colitis, with mesalazine. But along the way, we saw that there was not sufficient, and she had flares along the way, for which we started beclomethasone. This was the next step up treatment that we did. But unfortunately, these steroids that we gave to her were not sufficient, so we started a biological. So we already early on in the disease course, you can see here 1 year after the diagnosis, we already started her with adalimumab at that moment at the standard induction dose. But we tried also to discontinue the beclomethasone, which we did, but we saw that after 3 months that this wasn't sufficient. We had to restart the beclomethasone, and we also did trough level measurements of the adalimumab, and we saw that there was a very high consumption of the adalimumab, for which we optimized the dose, and we went to 80 milligram daily, which is a very high dose. So an optimization based on symptoms and also based on the biomarkers that we did at that moment. Unfortunately, this was not sufficient, so we switched the therapy because of primary non-response in this case to vedolizumab. Vedolizumab at that moment in March 2024 was started at standard dose with an induction week 0, 2, and 6, and then 8 weekly at 300 milligram. Of course, adalimumab was discontinued, but also here we saw that there was a response, but not sufficient response clinically and also on the level of biomarkers, and we adapted the dose. So again, we applied already with the two biologicals a treat to target strategy. Where we adapted the dose and increased the dose based on the assessments that we did. And now we are in November 2024, and this is how she presents. She was under vedolizumab for weekly dosing, and she had very important complaints, as you can see. She had severe urgency, rectal bleeding, a high stool frequency, and she felt really, really bad at that moment. She had cramping pain and also lost 5 kilogram of body weight. If we look to her endoscopy that we did at that moment, you can see it's severe colitis, not so extensive, only 25 centimeters that we have, but with a Mayo endoscopic subscore of 3 at that moment. And you can see spontaneous bleeding at the small pictures that you see here, spontaneous bleeding, large ulcerations, and a very severe inflammation. Biochemically, there were not really association between the endoscopic image. So we focused mainly on her clinical presentation and her endoscopy. Biomarker was not assessed at that moment. Fecal calprotectin was not assessed. So we started a third line advanced treatment after adalimumab and vedolizumab. So we started here in this patient with upadacitinib, Rinvoq, at 45 milligram. And discontinued the vedolizumab. After 4 weeks, we saw her back. So in December 2024, we saw her back. She had initial very fast improvement with low stool frequency and less blood in the stools, but there was a dip again at week 4 when we saw her again. She had again higher stool frequency. She had again more blood in her stools, and she lost weight further along the way. So she had in totally lost 10 kilograms of weight. Of course, we because she had an initial response, we thought it could be that this is an infection. We tested for an infection. CRP was normal, and stool culture was also normal. So we decided here just to continue until week 8, and at week 8 we did a reassessment. We saw at week 8 that there was a mild clinical improvement. So in January 2025, there was a mild clinical improvement with less blood in the stools, a lower stool frequency, and also the abdominal pain was better. But we did an endoscopy at week 8, so an early reassessment with endoscopy, and there we saw that there was still a Mayo endoscopic subscore of 3, some ulcer, but less bleeding, less extensive, and also to a shorter extent, not 25, but 70 centimeters. So we decided here we continue with a prolonged induction. So again, another 8 weeks of upadacitinib, which is possible according to the reimbursement in Belgium. So in total, she had 16 weeks of upadacitinib. And then we reassessed her after 16 weeks because she had already 3 advanced therapies. We did a new endoscopy and we saw that there was a further improvement. There was not a healing, absolutely not. It was remaining Mayo endoscopic subscore of 3. But again, you can see in the pictures here that it is healing along the way, but we are only 16 weeks along the line with treatment with upadacitinib. So we switched here as we saw a good evolution to upadacitinib 30 milligram, which we continued further along the way. And at the end of the year, so this is 1 year after start of upadacitinib, we did a new endoscopy and we saw that there was a complete mucosal healing with only some minor scarring and pseudopolyps in this way. This is a standard case, but you can see here we optimized the treatment 3 times for each advanced therapy. And this is really what treat to target is about. So what are the key factors if we are monitoring and treating patients with IBD in 2026? And I think there are 3 main pillars. You need to have a planning. It's the best way to treat them is following a treat to target strategy or an adapted treat to target strategy based on your local situation. And we also have to envision here that the targets that we have now in the treat to targets are really shifting. This because of the medication is getting better, but also because we are setting higher standards. Let's start with the planning. Planning is for me is everything if we treat patients with IBD. And I think what we apply here in our clinic is really following a strict care pathway in our clinic. And so we have when we see a patient with a new diagnosis or along the way with active IBD, then we discuss with the patient together with the IBD nurses what the plan will be for the coming year, not until the next consultation, but for the coming year. And we say we're going to start this medication, we're going to do the assessments based on endoscopy, biomarkers, etc. Along the way, and then we will see what we also discussed already upfront with the patient what we will do. I think very important in this aspect is also that we have a structured approach. For this, we use standard questionnaires for the PRO assessment. We use standard scoring systems for the endoscopy, also for the radiologic investigations like MRI or ultrasound, and also for histology. So everything is scored in a very standardized way, which makes it all possible to follow that plan and that structured approach, and also to really compare results from one moment to another along the way. We have in Belgium extended this approach to the whole country, and we had a discussion within the Belgian IBD research group where we asked ourselves, how can we optimize and standardize our approach for all patients in Belgium? And this is what we came up with. We had a Delphi round consensus meetings where we set the goals for our treatment and adapted the treat to target strategy to our local situation. according to what is reimbursed and what is possible and what we should do. So this is here for ulcerative colitis. You can see we collect patient-reported outcomes in a standardized way. We do the biomarker assessment in a strict standardized way, as you can see at the specific time points, and also endoscopy and radiology eventually can be done in that setting. We did the same for Crohn's disease, the same approach here, and this is how we work in Belgium. And this is very helpful. First of all, it's helpful to optimize the quality of your care in your clinic, but on the other hand, it's also very helpful because it's aligning us to in every center in Belgium to how we approach patients, and it makes the work that we do on research, for example, observational studies or retrospective studies, makes it way more easier. The second thing is a treat to target. And we talk already a long time about treat to target in IBD. And sometimes we think that we as IBD specialists have invented the treat to target, which is absolutely not true. I will show you here. This is a concept that exists already for a very long time, and it comes mainly from diabetes care and from cardiology. And this is here a nice example of a treat to target approach in cardiology. This is a study published in Nature Communications where they looked at the target setting for lipid control. So in patients with cardiac diseases, so the LDL control, and using different targets. And I think this study highlights really also what the importance is for treat to target in IBD. First of all, my takeaways from this type of study is that the real impact of a treat to targets, you can only see that along the way. You can see here, this is a study of 25 years of follow-up, where you see that the differences from implementing a treat to target study approach really come only after 10 years. And this is also in IBD is the same way. We really want to avoid those complications really in 10, 15 years. That's what we want to avoid. And the success of that is not seen always directly. Second, what we see is that we also see that applying a treat to target strategy gives us an advantage, but it will not completely solve the problem. It helps us improving the outcomes, but it will not cure IBD, of course. And a third thing is that you see also here that there is it is feasible to do this only with minor changes and minor setting of your targets. You can really already have a high impact on the final outcomes of the patient. So, and this is what we want to avoid in IBD with treat to target. We want to avoid that suboptimal disease control because it leads to complications, not directly, but after 5, 10, 20 years. We have, for example, in Crohn's disease, the structuring disease, fistula, surgery, etc., or quality of life that is bad for patients with IBD. And you might say, yes, optimal control, we try to do our best, and we try to have that optimal control. But in the real world, we see that control is not always optimal. This is a study, the podcast study, that showed that in approximately 50% of the patients, we have an incomplete control, a suboptimal control of the disease. And this can be based on signs of inflammation, of active disease, but also a lower quality of life, fistulizing disease in Crohn's disease, extraintestinal manifestations. So this is all signs of suboptimal disease, and there is, not in every patient, but in a majority of patients, there is an option to optimize your treatment and to improve that situation. And this improvement follows the treat to target strategy. You have probably seen this picture before, so you know currently the STRIDE 2 guidelines or recommendations have split it up into three parts. We have the short-term targets, which focus more on symptom control and normalization of the CRP. Then you have the intermediate target, focus really on calprotectin control, and then the long-term targets focusing on endoscopic healing. At the end of the road, let's say after 1 year of treatment, you really would aim for endoscopic healing and also normalization of quality of life. And this is what we follow here. Important here is that you have the different targets, but you should also be flexible in the use of these targets, and I will discuss that later. I've highlighted here endoscopic healing. And why is this is important? I think this has been shown several times already for both Crohn's disease and ulcerative colitis. We know if you achieve endoscopic healing in ulcerative colitis, you have lower risk for hospitalization, lower risk for relapse, less surgery, less colectomy, and more corticosteroid-free remission. The same is for Crohn's disease. Again, less disease progression, less hospitalization, less surgery. So this is really the final long-term target that we really aim to achieve in patients both in ulcerative colitis and in Crohn's disease. And this is highlighted also by the follow-up study of the CALM study. So just to set the scene, the CALM study was in fact the first real treat-to-target study in Crohn's disease, where we compared a group that was treated with adalimumab and the treatment was adapted only based on symptoms, and then the other group that was randomized to adapting the treatment based on symptoms, steroid use, and the biomarkers. And we saw at the end of the year that patients that followed that strict treat-to-target tight control, that those patients had higher rates of endoscopic healing at the end of the year. So if we follow those patients from the CALM study further on, 5 years later, 6 years later, then you can see that endoscopic remission that was really a driver for better outcomes over time. If those patients had endoscopic healing at 1 year in the CALM study and you follow them, they had less complication, less disease progression over time. And it was even better if this endoscopic remission was combined also with a complete clinical remission. When should you do your endoscopy? Well, there is some discussion about this, and this is an older study looked at this, where they found that if you do early on the endoscopy, that this gives better outcomes to achieve your mucosal healing. This is debatable when to do it, because it's also a burden for your unit and for the patient, of course. But I think most important from this study was that if you do an endoscopy, you also have to draw conclusions. You really have to show there that if there is active disease, that you adapt your treatment. It's only by adapting your treatment that you have higher chance of achieving mucosal healing. Just doing the endoscopy and just saying, oh, it's bad, and we do nothing, is not the best approach. This is the central thing in treat to target. There is only one study that focused on the endoscopic outcome as a target in a treat to target study. This was the Stardust study, what you can see here. So the Stardust study was a study with ustekinumab, so IL-12 23 inhibitor, that where patients were started on ustekinumab and were then randomized to standard of care or adapting the ustekinumab dosing based on the endoscopy at week 16. And the target here at the end of the study was endoscopic response. Just to be brief here, this was a negative study, and there's several reasons probably why this study is negative, because the target was not set high enough, and the dose optimization was probably not strong enough in this study. These are the results here, what you can see. So it's a negative study, not only on the primary endpoint of endoscopic response, but also on the different other endpoints. So there was no difference. So we are still waiting for a prospective study that really proves that targeting endoscopic remission that really gives us in a prospective way the ideal target in a treat to target strategy. And things are moving. As I said in the beginning, targets are also shifting at this moment. So we have now in the STRIDE guidelines the targets that we have defined based on CRP, based on fecal calprotectin, based on endoscopy. The example of endoscopy is that in the STRIDE guidelines that you should, in ulcerative colitis, aim for a Mayo endoscopic score of 0 or a UCIS of 1 or 0. But if you look closer into observational and retrospective studies to the progression of the disease and the outcome of patients depending on their level of endoscopic disease activity, you see that there is a difference. There is a clear difference between Mayo endoscopic subscore of 0 and 1, which is logic. That's why also it is 0 in the STRIDE guidelines. But if you look to the difference between UCIS of 0 and UCIS of 1 at the right-hand side, you see that there is a clear difference. So the question comes up whether deep is deep enough. So if we aim for that target, shouldn't we eventually go for the real deep target of UCIS of 0? This is for ulcerative colitis, and in the same way, we see that signal in patients with Crohn's disease. This is a French study where they compared patients with Crohn's disease that had, according to the definition, a endoscopic remission, but they looked at again at patients with a complete endoscopic remission, so absolutely no lesions, and those with an well, let's say almost endoscopic remission, so a partial endoscopic healing. And you can see here again the same signal. If they have absolutely no lesions at all, then those patients do better over time. They do better over time on recurrence rate, but they do also do better over time at stronger endpoints like hospitalization. So patients with partial endoscopic healing have more hospitalizations, have more need for steroids. And then we can also look even deeper. We can look also at histology. And histology and ulcerative colitis might in the future be a target, as we know that this is an achievable target, first of all. But we also know that if patients have endoscopic remission, but still having histological disease activity, those patients do worse, as you can see here, over time, and have more need for steroids, more hospitalizations, more colectomy even along the way. There's also a shift in new frontiers. We go for new frontiers in treat to target. Ultrasound transmural healing was not included yet, but probably will be included in the next version of the STRIDE guidelines. Important to know is that that assessment of intestinal ultrasound should be done approximately, probably in the beginning, that we do it in the beginning to assess that after 3 months, because there's no additional gain in the further if you follow those patients further on along the road. So the main gain we see after 3 months. So I think the place is there, and we also focus now more and more on other outcomes, really the quality of life and different outcomes in treat to target, which should be adapted as well. So like bowel urgency, like tenesmus, nocturnal bowel movements, etc. So now have to finalize, have a look also what this impact is here in on of IL-23 and JAK inhibitors. What are the results showing us for the treatment of patients with IBD and that shifting targets? So first thing I wanted to highlight here is that that we also saw in the studies. This is the study of upadacitinib in Crohn's disease, that there is an impact of disease duration, and this is very clear here. What you see here, if you have a disease duration at the left-hand side of less than 2 years, your chance of achieving mucosal healing after 1 year of treatment is double as those patients having a disease duration of more than 5 or 10 years. So the takeaway here is that we should treat those patients early on in disease, like I have shown also in the case. Similarly, here, this is for ulcerative colitis. Again, the trial with upadacitinib, you see here that whether a patient is biological naive or biological exposed, that patients that are bio-naive have higher chance of achieving endoscopic remission at the end of the year. So treating early on, not waiting to start a treatment, is really important, because that smoldering, ongoing inflammation leads to worse outcomes. And then you can also see here, and this is a very clear example, why endoscopic remission is so important. These are two outcomes that we saw in the study, in studies with one risankizumab at the left-hand side and upadacitinib at the right-hand side. You see that those patients that had endoscopic remission at week 12, so endoscopic response and endoscopic remission at week 12, this really impacts on the hospitalization rate. You can see it here. The incidence of the need for hospitalization in those patients is decreasing enormously if they achieve early on the endoscopic response. And this shows also the shift of the treatments. You go from rather symptom control early on in disease to really healing of the mucosa early on in disease. It's still a target, a long-term target, but if you achieve that longer term target already early on in the disease course or the treatment course, then the impact is enormous, not only on hospitalization, but as you can see here, also on quality of life measured by IBDQ. So again, patients that achieve mucosal healing at week 12 have better quality of life at the end of the year at week 52, and which is also integrated now in the clinical trials and showing that the newer drugs have impact on is also the newer targets. You can see here tenesmin, fecal incontinence, nocturnal bowel movements, sleep interruption. You can see here in the study with ulcerative colitis and risankizumab that there is a clear impact of the drug, and this impacts really on the long term on those specific outcomes. And with this, I like to end, and I'm happy to have the discussion afterwards. I think the takeaways of my talk are that the planning is everything. It's all about the planning. You need to have a plan, a structured approach. That's the framework where you can do your treat to target in. The treat to target is evolving, and it will evolve in the coming years. And with the newer compounds, the IL-23s and the JAK inhibitors, it is possible to achieve those targets, and those newer shifting paradigms are also followed and achievable by IL-23 and JAK inhibitors. With this, I'd like to thank you and happy to have a discussion.